Hello friends, welcome to my new video. So today in this video I'm going to discuss with you all about a scan. Let's start. So a scan is the most common equipment used in ophthalmic practice. And basically a scan is used to measure the axial length of the eye. So a scan is also known as amplitude scan. There is several types of use of a scan that I will discuss later on. So, what is the principle of S scan? As I said that S scan is also known as amplitude scan. So, S scan uses ultrasound which is having the frequency of 10 to 12 megahertz. We can hear the sound range in between 20 to 20,000 hertz, but S scan is using 10 to 12 megahertz, that is very much higher frequency. So this ultrasound is sent by the scan probe and it will go through the ocular structure like cornea, lens and then lastly retina, and it will again return back to the receiver of the probe, okay, and then the display will show. So depending on the density of the structure, the ultrasound pass through that and return back, it will create some echo, and that is where amplitude word is coming, that how much the height it is, so that we can assess the ocular structure that what it is. So this is why it is called as amplitude scan also. Now you are looking at the scan machine. It is from Alcon, where scan as well as pachymetry can be done. So this probe is scan probe, and the other probe is the pachymetry probe. Okay. Now what are the components of scan? The scan is containing pulsar, probe, receiver and display unit. Pulsar will send the ultrasound via the probe, and receiver will receive the reflected ultrasound, and display unit will show the echo. Okay. Uh, so there is several types of scan procedures, that contact, immersion and automatic. So contact scan. So in contact scan procedure, a probe is used where the probe is cleaned properly, and after putting anesthetic drop in the patient eye, the probe is touched to the patient central cornea, and it focus to the macula, and um, the ultrasound is sent. So that ultrasound will pass through the ocular structure, and some echo will be seen in the display unit. So this is how contact method is performed. So in contact method we can see four echoes, one in the cornea, one in the lens, two in the lens and one at the retina. So one at the cornea, one at the lens anterior surface, one at the lens posterior and another at the retina. Now there is some disadvantage of this contact scan method, that the examiner will need to do some applanation, that means applanate, that means little pressure apply on the cornea by that probe, so that the ultimate axial length of the eye which is get is little bit lesser than the actual. So there is a error is remaining. So this is why another method is came, that is immersion method. So this immersion method, you are seeing the bluish background, that structure that is known as pressure scleral shell. It is just put on the probe of the scan. So and after that the patient is lying on supine position and immersion is performed. uh, we can perform the contact scan method in sitting position as well as standing position, but immersion can be done in supine position, where the pressure scleral shell is attached to the probe, and after that saline solution is put. And in immersion method, the probe do not touch the corneal surface, so that there will be no indent in that means there will be no applanation, there will be no error, and it can be easily performed. So after putting the pressure scleral shell in the probe, it will look like this, and from this the pipe of the syringe will inserted, so that to allow saline solution to pass through the corneal surface, and after at that time we will put the ultrasound. So it is very useful method, and it has also have very less error. Now you are seeing the contact method here, that the probe is placed on the center of the cornea, and it has sent the ultrasound to the it through the ocular structures. So as it pass through the structures, like in the cornea there is a spike is creating, after that the second spike is created in the anterior surface of the lens, and third spike is created in the posterior surface of the lens, and the fourth or last spike is created at the retina. This is how contact scan is performed, or it shows the result. Now in immersion method, the uh, uh, display of those spikes is little bit different from the contact method. Here an extra um, spike it can be seen in the first, that is you can see that the probe it has itself a spike there, and after that cornea have two spike, cornea anterior, cornea posterior. After that lens have also two spike, there is lens anterior, lens posterior, and after that retina sclera, that means retina, choroid, sclera, these are having several spikes. So this is the report of immersion method. Now you can see here that the similar pictures that I shown earlier, that the orientation of the spikes depending on the structure, ocular structure. Okay. Now what are the uses of a scan? So a scan is basically used to calculate the axial length of the eye, uh, to calculate the intraocular lens power. S-scan is also used to calculate the AC depth, to calculate the lens thickness, and sometime we can estimate any ocular lesions also by seeing an abnormal spike or echo. We can estimate that it can be a retinal detachment, or there can be a foreign body like this. We can estimate that there is something abnormal is going on, and we can refer, or we will refer that patient to V-scan for proper evaluation of his posterior segment. Okay. Now in A-scan, the main use of A-scan is to find out the intraocular lens power. Okay. So to find out that intraocular lens power, that procedure is known as biometry, where A-scan and keratometry values are used. Keratometry value means curvature of the cornea, that is the vertical corneal curvature, horizontal, and the mean K. These are added with a scan value to calculate the IOL power. So IOL power calculation, there is a formula is used, that is called as SRK formula, that is the standard formula to calculate the intraocular lens power. Now, this SRK formula is that P is equal to A minus 2.5 L minus 0.9 K. Here, A is a constant which is changing depending on the material of the intraocular lens. L is the axial length and K is the keratometry reading. So, if there is a miscalculation of the IOL power, it can lead to uh, overcorrection or undercorrection of the eye after putting the IOL power in the capsular bag in cataract surgery. So, this is the reading that we can get after performing a scan through immersion method. That at first we can see here the probe spike, and after that C1 C2 is the corneal anterior and cornea posterior spike, and after that L1 L2, that is the lens anterior and lens posterior, and after that retina, it is denoted by R. So, here you can also see that there is type is mentioned that it is a phakic eye. So, we need to mention that whether it is phakic eye or whether it is aphakic eye, or whether it is a pseudophakic eye, because in every eye the sound beam need to travel in different time. Okay, so depending on that time, the distance of the eyeball is measured in a formula, that is distance is equal to velocity into time. So how much time it take to travel through the ocular structure and multiply it by the velocity. By this method, the distance covered is measured. So here the sound beam need to travel through all the ocular structures at first, and after that it get returned again, and then only the spike will be displayed. So the sound wave is traveling twice the distance, so it is divided by 2, and after that we can get the axial length. So all these calculations are done automatically in the scan machine. So there is, we need to mention also technique, whether it is contact or immersion. So you can see technique, it is immersion. Now here you can see a word that is gain. So what is that gain? So gain means like it is the intensity of the sound wave, that higher the gain, that means higher the intensity of the sound ultrasound. Okay, in normal patient, to measure the axial length, we we make the gain at about 60 to 66, and if the person is having a very hyper mature cataract or total cataract, then we need to increase the gain above 70. Sometime it can be 76% or 75%, 74%. So higher the gain, then higher the spike will be there, and higher the penetrating power of that ultrasound will be there. So if we perform higher gain in a normal patient, then it can show a false reading. So in a normal patient, we need to set the gain at 65, and after, if we see or notice that in 65 we are not getting the proper echo, then only we will increase the gain percentage. And after putting the immersion method, uh, this reading will come, as you can see in the right side, that there is 10 readings is there. So you can choose any the best axial length, which is very after seeing the spike on the display, that which one is good. and here also you can see the AC depth that we can also calculate by scan method, and then it is the lens, and then it is the vitreous depth, all are measured here. So this is the display of that scan which I showed, scan machine by Alcon. Now this is the report of IOL power that we get after that we get for IOL implantation. That here you can see that there is axial length is mentioned, CCT is mentioned, there is central corneal thickness is mentioned. So after AC depth is mentioned, lens thickness is there, R1 R2, that means the K readings these are, and it this reading is from the automated scan machine, that is a company I know, it is a Landstar machine. So that machine give a suggestion of different types of IOL material, IOL, and also it is all that machine also suggests which power is suitable, but ultimately decision depend upon the doctor, that whether he want to make the patient myopic so that in the later time the person will feel less difficulty to read the near objects, or whether he want to correct the patient full correction. It is depend upon the surgeon who is performing that cataract surgery. So as I discussed that the gain, that means higher gain means higher spike, lowest gain means lower spike, but we need to set the gain at 64 to 66 at first, and after that if we notice that there is some abnormality in the spike, then only we will increase the gain. Now velocity of sound, so there is a varying velocity of sound is there in different eyes, like in aphakia the velocity of sound, that means that ultrasound the velocity is 1532 meter per second. In phakic eye the velocity of that ultrasound is 1550 meter per second. In pseudophakia here two type of IOL material are used, that is PMMA or silicon IOL. In PMMA the velocity of that ultrasound is 1550, and in silicon it is 1486. And lastly, if the patient is having silicone oil injection in his eyes to repair the retinal detachment, then the velocity should be set at 987 meter per second. Now there is some limitation of a scan machine, that is the small tumor. So if there is any small tumor is there, then it can form some abnormality, so there will be a an error in the axial length calculation will be there, so that we cannot calculate the axial length properly. So there is a limitation, and another limitation is that a contact method, there is we need to aplanate, so that there is ultimately an error is coming, that we need to aplanate, so the axial length is little bit lesser than the original, so it is a limitation. And in case of nystagmus, that the patient is not able to fixate his eyes. So in immersion method, or is in contact method, there is in the probe there is the red light is the red light is there, and we instruct the patient to see a distant object, or to see the red light. So if the person is having nystagmus, then he is not able to fixate his eyes to a fixed position, as his eyes are having continuous movement. So it is a limitation, and there is very difficulty to measure the axial length of the eye at that situation. Some contraindications are, if the person is having perforating injury, then we will not perform a scan at that patient. And if the person is having corneal ulcer like severe corneal ulcer or corneal scar like macular or leukometer scar or any type of those severe ocular infection, then we will not perform uh, a scan there. And also if there is discharge from there like mucopurulent, purulent, this type of discharge is there, then we should not perform a scan. First of all, we treat the patient, that means treat the disease, and after that we will perform a scan. And that's all. And there is a tip for all of you, that after every performing procedure of a scan, whether it can be contact or immersion, you should clean the probe by the alcohol swab to avoid any type of infection, because in immersion you are putting the pressure scleral shell on the patient eye and putting the saline solution. So if the patient is having any type of infection to his eyes that you may not know, and after not cleaning it properly you are using that the same probe to another patient, then it can be a risk of having infection to that patient. So don't forget to clean the probe after every use, whether it can be contact or it can be immersion. But nowadays immersion technique is getting more popular than contact, because immersion technique are more accurate than the contact method. And in immersion we can get 6 echoes, and in contact we are getting only 4 echoes. 6 echoes means 1 echo for the probe, 2 echoes for the cornea anterior and posterior, 2 echo for the lens that is anterior posterior, and 1 from retina. So that's all friends. Thanks for watching, and please don't forget to like my video and subscribe to my channel. Thank you so much.